I put the list on the side to see who all's here. So I'm going to go ahead and do roll call, and I guess I'll just figure it out that way. I hope you guys are all well. Okay, good morning. I'm Kimberly Hendricks, and I'd like to call to order the PEB board meeting for December 21st of 2021, our last board meeting of the year. So it's amazing how fast the year goes. Kate Nass, are you with us?
I am. I'm just going to step away for a quick minute while I transition kiddos from one place to another. I have grandparents picking up, so I will be right back.
Perfect, thank you. Kim Harmon. Or do we have Kim has a replacement, doesn't she, Allie?
Not till next month.
Oh,
Kim's
okay.
she's on vacation today, so she won't be here.
Oh, okay, perfect. Sean Parkman.
He is also on vacation.
Oh, gosh, I'm sorry, and I apologize if you sent me all that in emails. Good morning, Mark Perlman.
I'm here.
Good morning. Saban Martin.
I'm here.
Good morning. And Jeremy Vandehey.
Morning, it's Jeremy. I'm here.
Good morning. So this is Mark's last meeting with us, and Mark Perlman has been absolutely, I think, a key member of our team and has always had the best questions and wasn't afraid to challenge uh, presentations and ask really deep dive questions. And we just, all of us board members, want to thank you so much for your dedicated service to PEB and really to the state of Oregon. And I want to give you, I just think it's important to give you a nanosecond or more to say whatever you would like to say to us, Mark. And again, we appreciate you so much, and you will be missed. You will be missed.
Thanks, Kim. It's been quite an interesting ride on PEB. I was amazed at how long it took me to figure out all of the acronyms, and there are many that I still haven't figured out. But also just figure out how all of this works. And but I've always been very impressed with how seriously the members of the board take their task and really diving into the details. And it's been a pleasure for me to be on the board. And I started out, I think, halfway through somebody else's term who had left, and then I had a whole term. And then I stayed for a few more months while people were looking for a replacement. So I think I've learned a lot, and I've really gotten a good understanding of how complicated things like this are, and how many people it takes to get something like this to run smoothly and effectively. And I just always impressed by how conscientious members of the board are, and the staff and Ali, of, threading the needle between doing what's in the interests of the state of Oregon and saving costs versus also taking very seriously the interest of our members and not wanting to raise costs to them. And it's a complex thing to do that, both of those things at the same time. And so it's been really interesting being on the board, and I'm appreciate that all of the work that everybody does. And for myself, I wish that I was leaving, and my dog wants to have a little say as well. I wish I was leaving under a little bit better circumstances than, there's nothing about PEB, but my position at Western Oregon University. Western went on a budget cutting binge and decided to get rid of the philosophy minor and major and half of my department, including me. So part of the reason why I couldn't continue is because Western's laying me off after 23 years of teaching there. And the most insulting thing about that is that they did it under the auspices of a financial crisis, and then 3 rounds of federal money meant that they ended up with a budget surplus last year. And so that account makes it sort of sour for me to have PEB be connected with Western after the shabby way they've treated me. But PEB has always behaved admirably. So I'm going to not make any more speech and let us get on with our meeting. Thank you.
Thank you. Thank you so much, Mark. All right. So our first order of business is we need a motion to approve the minutes from November 16th. Do I have a motion?
This
So
is
moved.
Oh, and I'll second then. You beat me to it. Nice, Mark. And I've really appreciated you too on the board.
you.
I'll miss you.
So if Mark has taught me anything, I need to now, anybody have questions or changes to the minutes? I don't just go right to done, approved, good to go, right? Okay. Is there anyone opposed to approving the minutes? I think we are all on screen. No one opposed. I believe we can say the minutes are approved as presented. All right. So then we have, we're trying to, if it seems a little rushed, I am trying to get a few things done. Do I have a quorum, Ali?
Yes, you do.
I do. So we're trying to get a few things done before I don't have a quorum, or we don't have a quorum. And so up next is, sorry, I got to switch pages. April and Glenn are going to be presenting.
Perfect. Thank you so much. And I just wanted to quickly, I really laughed at the acronym thing because I don't know if it's a benefits thing or if it's a state thing, but we tend to talk in acronyms, expecting everybody to understand it. So it's almost like our second language. I really think that's funny. Okay, so I do have Glenn here. I saw that he's on here just in case you guys had any questions about this rule. So we brought you this rule back in September, and we're looking at, let's see, Division 65, Section 10001, which is page 4 in your PDF packet, and Rose, love her, has it up on the screen here for you. But anyway, we brought these to you back in September for review and approval. We did file them temporary since the Senate Bill 551 became effective October 1st. We wanted to make sure that our rules were also effective October 1st. We did work collaboratively with the implementation team with the universities and community colleges. We wanted, our goal was trying to get the rules as close to, the temporary rules as close to permanent that we could at the time. And we almost accomplished that goal except for one small adjustment, which you'll see there that's highlighted, that came in from the Oregon Community College Association, which represents 17 community colleges. And their one comment was to add currently and add employer paid benefits to section 1, the definition of SB 551 eligible member. And we talked about that, and that absolutely we agreed with their recommendation. So I'm back here requesting approval to file these permanent, which I will be then repealing the temporary rules and then making these permanent with the Secretary of State's office. So does anybody have any questions?
Thank you.
Even about the program?
Thank you so much, April. Can I have a motion, or would someone like to comments or questions and then a motion?
This is Siobhan Martin. I'm happy to make a motion that we support this as written, that we approve it as written with the updates.
This is Mark. I'll second.
Thank you. Any questions? Okay, let's go ahead and we will do roll call real quick on this one. Kate Nass. She might be still loading babies, huh? Shaw, oh, sorry. Jeremy.
Yes.
Okay, and I vote yes. And Kate, did you join us?
Hi, I'm back now.
Okay. Kate,
Sorry.
we have a motion to approve these rules, this rule to go to permanent versus temp. Is that something you're willing to vote for? And do you vote for or against?
Was there any changes to what was sent out? Just sorry.
There was 2 words that were changed. Rose, if you could back up a
I'm
slide.
so sorry, everyone.
No, you're fine. You are totally fine. We added who is currently eligible for employer paid benefits.
Got it. Okay. But yes, I am okay with that.
Thank you. Okay, and I believe I need to vote today. Is that correct, Ali?
That's correct, Kimberly.
And so I also vote in the affirmative, aye, for the this to go forth towards permanent adoption as written with the 2 changes that are highlighted in yellow. I believe that makes this pass. I'm sorry.
Yeah.
Too many moving parts to this one. And so thank you so much, April and Glenn. And we appreciate you coming before the board today.
And then I just have one more rule. Sorry.
Oh, perfect. No, you're fine. Okay.
And yeah, so this is
Yes.
in your attachment 2A. This is our PEBB's Division 15, their eligibility division. So the reason we're bringing this to you today is back in 2019, PEBB staff met and went over basically all of our administrative rules as we do. Sorry, my cat is like trying to drink my water. As we do probably every couple of years, just to make sure that our rules match our processes and that any language needs to be updated. And so we did this collaboratively. Our staff did back in probably the summer and fall of 2019, and getting ready to file those and to get that ready in kind of the early part of winter 2020. And then we all got sent home, and we had a directive that there was going to be no non-COVID rulemaking, which totally makes sense. And so we didn't proceed with any of these changes. But we wanted to bring this to you today because we do have a change. Senate Bill 748 came out of the 2021 legislative session, which expands eligibility for disabled dependents. And so we went back to what we had worked on before and kind of made sure that all of the kind of housekeeping, clarifying language still applied. And then we added in that the section about the expanded eligibility. So a lot of the changes you'll see here, there's nothing that's substantive. Again, we had our staff review them just recently just to make sure. And most of what you see either added or deleted is just to clarify and update the rules to match our processes in our current language. So we are asking to, I'm not a fan of filing temporary rules. However, the bill does become effective January 1st. There was a little bit of delay with some language. We were working with our counsel at Department of Justice because we wanted the language to be right and be correct. So hence why there was a little bit of delay with that. And so with that, I am asking approval to file these temporary and then go through the permanent rulemaking process. And when that is complete, then we'll bring these back to you for final approval for permanent.
You know, April, sometimes we just have to do those kind of things. It's like, it just happens. So we appreciate.
I did try to work out everything. I just didn't want to rush it. That's the thing. You just don't want to rush the process. So yeah.
Right. Yeah. All right, board. What do you think?
This is Siobhan Martin. I'll make a motion that we approve these housekeeping changes as written.
Okay, and
This Mark, I'll second.
Okay, Mark, second. Okay, any questions? Okay, we'll go for vote again. Kate Nass?
Yes.
Mark second, Siobhan first, Jeremy?
Yes.
And Kimberly, yes, in the affirmative. Looks like you, April, you have your marching orders to go forth and prosper.
Perfect. I really appreciate it. Thank you so much for your time.
Thank you for being here, and have a happy holiday.
You too.
All right. We are now up to Jeremy. Yay! we get to listen. I love this. Jeremy gives us such great updates. So good morning, Jeremy. It's all yours.
Thanks, Kimberly. So wanted to give folks a quick update on the Value-Based Payment Compact work group, which is part of the Value-Based Payment Compact that PEBB and OEBB and most payers and health systems across the state signed last year. Part of the compact was the stand of a work group of representatives from a variety of different places within the health system, including representatives of PEBB and OEBB. And the work group's been meeting for the last 6 months or so. I wanted to give a quick update of where we're at. This work is still pretty early, and we'll want to do more updates as we get more into the weeds. I want to go to the next slide. So just a reminder, so this work really is a spin-off out of the cost growth target work. We had the implementation committee for Senate Bill 889 establishing the statewide cost growth target that met over the last couple of years. One of the things that they considered and were charged with was looking at strategies, including payment reform, that would help set the state up to be both successful to meeting the new cost growth target of 3.4% statewide. And so the group looked at a variety of different things that we could be doing as a state, and ultimately landed at payment reform really is the thing that would really need to lean in on to make ourselves most set up for success. I don't think value-based payment in of itself, by itself without anything else necessarily, it's going to help reduce costs, but thinking about the other direction, that if our goal is to reduce costs, that a key strategy of that is to really move from a fee-for-service system that really pays and has a financial incentive to provide more and more services and even low-value services to payment models that really reward population health and reward better health, and ultimately that helps lower costs. I think about these as two sort of now parallel bodies of work. So the cost growth target is its own program. We'll be measuring cost growth on an annual basis. There's a committee under the Health Policy Board that's going to continue to provide advice on how that moves forward. And then we've really stood up a separate parallel body of work that's really going to be focused on how we move towards value-based payment at the same time. The Senate Bill 889 implementation committee had tasked OHA with trying to get all the major payers and providers and state markets to sign on to a compact committing to aggressively moving towards advanced value-based payment over the next couple of years. And we've been very successful in being able to do that. I think this is the largest commitment that we've seen of any state, with a widest number of sort of players signed on and really committed to moving aggressively towards value-based payment. Has caught the eye of a lot of national organizations that are watching this, including our federal partners, who have been really looking at this work unfolding and seeing Oregon as really a leader of the pack nationally. Next slide. I want to go to the next slide. So taking a step back before getting into the compact, just a refresher on what we're talking about when we're talking about value-based payment. And this has been a strategy that the PEBB board and OEBB board and OHA for CCOs and others, we've all been marching in this direction of this as a priority. And what I think the compact does now is create sort of commonality across markets, across programs. This is a commitment that everybody's really committed to, and something we all need to do. And now we really need to do it in a more of a aligned fashion. Before I get into the details of where we're headed, just what value-based payment is. So think about it as it'd be nice if it were just sort of like black and white, like today you got fee for service, tomorrow you got value-based payment, but unfortunately it's a bit more complicated than that. And it really kind of goes along a spectrum. And the type of value-based payment that ultimately insurer and provider will enter into sort of depends on a variety of factors. And probably biggest two are how big is the provider and how many patients do they have. And that really dictates how much they can really move away from fee-for-service. But thinking about a spectrum on the left where we've been largely as a country is a fee-for-service system. You largely just pay providers just based off of the number of services they provide. That's about it, not really linked to quality or value or outcomes. And we've been, I think, moving the last 10 years further into category 2, which is paying primarily off fee for service, but you've got some ties to quality and value. Maybe you've got you're paying for reporting certain data that helps you measure quality, or you've got sort of quality bonuses for certain targets. So the chassis really is fee for service, but there's some payment going back and forth based off of quality. As you move into category 3, that's where you start to have providers actually at risk, meaning that if costs or quality if costs go up or quality goes down, that the provider is on the hook for some of that cost. And likewise, if quality is going up and costs are going down, the provider is sharing in some of that savings. So then you're starting to get to the spot of the payers and providers having some sort of joint accountability for cost and quality. And then as you get into category 4, the most advanced, you're really starting to talk about a population payment. You're really talking about a provider who is getting sort of a global budget or a monthly payment for all of their patients, and they really are paid for the population health regardless of how many services are provided. So that's sort of the most advanced. Next slide. What was in the compact that was agreed to was that over the next 3 years that all payments, sort of the total sum of all payments from insurers out to providers, that we get to the spot where 70% of those were in category 3A or higher, and that we'd also get to the spot of 70% of payments to hospitals and primary care would be in 3B or higher. So those are the targets that are committed to now across markets. And I think the across markets piece is really important here, because when we're talking about moving from fee for service to value-based payment, this isn't just a Medicaid problem or just a PEBB problem or just a commercial insurance problem. This is fundamentally changing how we pay for healthcare across the whole delivery system. And so I think a big value of this compact is creating a commitment that's really across markets and recognize this is something that we're going to be more successful at doing if we can do it in an aligned way. Next slide. As I mentioned already, the biggest commitment we've seen, we have 47 organizations signed on, including all of the major insurers in the state, all the state's lines of business, Medicaid, PEBB, OEBB, commercial insurance, marketplace. If you look at it from an insurance perspective, the number of signers represents about 3/4 of the population. Those 3/4 of all the insured lives in the state are basically their insurers have signed on to the compact. Next slide. A lot here. The overall goal of this work group, so that there was the compact, and then the compact included standing up a new work group, and the work group was really aimed at being a place where there was a group of folks really dedicated to figuring out how do we've made this commitment, how do we actually do it now? How do we really accelerate the adoption of value-based payment? What are the obstacles and barriers? And as we're running into obstacles, how do we have a forum to raise those and then figure out where that obstacle, where the fix needs to go? Is that a legislative fix? Is it a PEBB fix? Is it a health system fix? And so that's the idea of this group is to really start to think about how do we actually now move forward on meeting these targets. There's a charter for them that includes first establishing a roadmap for how we move forward on meeting the targets and shifting these payments from fee for service to value-based payment. That's task 1. 2 is coming up with an evaluation framework so we can monitor progress and the impacts on cost and quality. So we're evaluating and learning as we're moving from fee for service to value-based payment, what's working and what's not. That they would identify challenges or barriers over the next couple of years and escalate those up to the right place, and then and that there would be transparency in this and would develop a way to do annual public reporting. Next slide. So this is the representatives of the group. It's a sort of co-hosted work group across OHA and the Oregon Health Leadership Council, which is a association of the major health insurers and health systems and provider organizations in the state. So we went through a process of selecting a number of folks. I won't run through all the names, but I think a really great, very energized group of folks that are really excited about this, including representatives from sort of all corners of the state, hospitals, FQHC, clinics, insurers, CCOs. I'm on there, both representing OHA and the PEBB board. Tom Siltabo is on there from the OEBB board. Kirsten Isaacson, who's not on the PEP board, but is a member of the Oregon Health Policy Board and also works for SCIU, is on there. And so a really good group, diverse group that seems, like I said, very energized around this work. Next slide. As I mentioned, there's sort of several tasks, and they're still on the first one. But the first one is really identifying a roadmap that will outline how we can help accelerate value-based payment and challenges and barriers. Expect that as they go further into their work, they'll start fleshing out potentially policy changes or other types of solutions as we're running into barriers. To give you an example of things that will come up, there's been a lot of discussion of, if you want to move to value-based payment, you've really got to have folks have a primary care provider. That's kind of the link for figuring out how you can make sure they're connected to the health system. And so in places in the insurance markets where there isn't a requirement that people have a primary care provider, how do we navigate that? Those are the types of things that the group's working on, and expect they maybe bring recommendations back to PEBB or OEBB or to the legislature or others for how to handle that type of thing. And then eventually they'll get into really a monitoring and reporting role. Next slide. Christmas music, great. So the first step right now is this roadmap that they're working on. They don't have the contents nailed down yet, but they've been really fleshing out just on the front end initial sort of challenges and strategies for early adoption work, and where are the biggest barriers to earlier adoption, and what are the potential strategies. Big struggle that the group's going to come in with is how to prioritize. This conversation very quickly sort of erupts into like complete health reform. Kind of starts with, okay, we need to move towards value-based payment, and then pretty soon it's, well, we need to have aligned quality measures, and then it's, well, we really need to have better electronic health records that help us capture those quality measures, and then it's, well, how do we really create the data systems to be able to collect all that? So finding their right scope and focus is I think the biggest struggle that the group's going to have, and recognizing that they can't sort of boil the ocean. They've got to find a couple of the key things that we can do that help propel this work. Next slide. So a couple of the challenges and potential strategies that the group's looking at. Challenge one, lack of will to change within the system. Group's been thinking about things from and actually planning to do this one, launching a survey to get a better environmental scan of what the challenges are and willingness to change on the ground. They've talked about sort of communications tools, creating a provider toolkit or readiness assessment information, things of that nature that would help explain why this is important and help get more buy-in from providers. They've also looked at potentially things like sample contract language or guidance that would help, especially smaller providers, understand, what a contract language would look like for value-based payment. That might make that easier for them. I've looked at technical assistance, potentially some type of incentive grants or payments. I should note there's no sort of bucket of money from the legislature for this. So these are sort of ideas, not all of them feasible financially yet, but just sort of throwing stuff at the wall. Also looking at possibly publishing a public report that would, again, provide some more transparency, but also sort of nudge folks in this direction by sort of shining a light on who's being successful and quickly moving from fee-for-service. Next slide. Another challenge is fear of financial loss for providers. This is where the element of how big or small a provider is really dictates how far they can get on that spectrum. A very large health system is going to have much more of an appetite to have more financial risk and be able to sort of take a single population payment and feel pretty comfortable with that. You know, a clinic with five clinicians is going to feel, you know, much more nervous about taking financial risk. So I've looked at technical assistance or creating glide paths, trying to educate providers or find some ways to provide some sort of wraparound support for providers to give them some security around potential losses. So, you know, in the insurance market, we would think about these as things like reinsurance or stop loss that sort of protect an insurer or self-insured plan from too big of a loss. Thinking about some type of similar types of things for providers or risk corridors is another alternative there. Next slide. Another challenge is small patient populations that sort of is coupled with small provider organizations. So the group has looked at ways to potentially combine populations across multiple providers to create a bigger pool, be able to look at different risk adjustment methodologies, or to leverage independent provider associations or clinically integrated networks. The small patient population challenge at the end of the day is a small numbers issue of a concern that you've got one expensive patient that sort of completely skews your payment methodology for the year, a challenge like that. Next slide. Another challenge is around multiple value-based payment models. So for all the challenges that the fee-for-service system has, it is a common payment methodology that pretty much everybody understands. No, I don't think anybody at a provider or a patient level understands it when you get your bill, but everybody's got tools and knows how to sort of bill for stuff. As we move into value-based payment, there's a big risk and probably a likelihood that we actually will make things more complicated because we may have multiple different types of payment models, even to the same provider. So there's been a lot of discussion in the group of should they really be coming up with just a couple of payment models, and should we be really embracing, say, 5 payment models and that's it, and not having 35 different value-based payment models. And there's a lot of discussion among the group of whether we should be doing that or not. I think this is an important issue because I think this is an area where likely we'll want to have some more discussion with the PEBB and OEBB boards of really how does the state lead in this space? Do we create a couple of open source, for lack of a better term, kind of payment models across PEBB and OEBB and the marketplace or OHA's lines of business and sort of start to drive some alignment as opposed to just having it just be sort of a free for all. And so I think this is one of the hottest topics right now among the group is how much should we be aligned on the actual payment models or not. Next slide. So more to come. As I mentioned, the group's just been up for about 6 months and will be around for several years. They're going to be continuing to fine tune their strategies. They're going to need to go through a prioritization body of work. I think I've been really pushing hard and will want to push probably even harder, frankly, going forward, that as we start to move into not just talking about the payment models, but actually what they are, making sure that they're really grounded in equity. There's a huge opportunity here to not just pay for value, but actually be paying for outcomes in a way that's improving equity. And I think making sure we don't miss that opportunity in this process. And then eventually, once there's a list of strategies, figuring out who does what, what's the role of the state, what's the role of private market or other players. So more to come.
So Jeremy, how often do you think you want to update us? Or it seems like it's been a while, but now that you've got this kind of new group, or it's morphed into this new, what are you thinking that we should maybe look forward to, or just when you have major action items that you want to notify us about? Or
just kind of shooting from the hip, I'd say maybe quarterly would be good.
Okay.
And maybe up or down from there, depending on if there's not much happening, you could skip, or if there's a major milestone, maybe more often.
Okay, thank you, because this is good stuff and we want to partner with you.
Thank you.
And Kimberly, I would just mention that after the consultant RFP is concluded, likely by February, we'll be updating where we're currently at in our percentage of expenditures in a value-based payment arrangement. And also advancing VBP is a huge priority of the innovation work group this spring. So that work will really ramp up in coordination with the VBP work group as well as both boards. So we'll continue the momentum here, and as Jeremy said, really accelerate this this year.
That's wonderful. I think the more directions, you don't want people going different directions, but the more that you're coming towards a common direction, I think helps. Kate, you have your hand up.
I do. I'm always really excited about this kind of work. So thank you, Jeremy, for the overview. I want to underscore the advancing health equity. I think one of the things that I just want to make sure is that there's the right outreach, that this group is talking to the right groups and the right voices are heard. So I just kind of want to put a pin in that for Jeremy, and however you can bring that back to the group. These are really strong health leaders that are on this group, and I just want to make sure that we're getting the voices of the people who may have been a little bit left behind on the health equity piece. So for what it's worth, that's my understanding.
Thanks, Kate, for bringing that up. I couldn't agree more. And as the group was fine-tuning membership, went back actually and got 2 or 3 new members of folks who specifically had experience in equity, a couple of community health centers that bring that experience, and some folks who have had some experience with trying to develop value-based payment models that specifically are tied to equity. But I think I totally couldn't agree more, and there's a lot more work to be done there.
And if I may, can I have one more comment? The other thing is I want to make sure that we talk about provider capacity. I know that's a huge problem right here across our health system, and I know it's underpinned throughout all your conversations, but I just want to put a pin in that one too. Yeah,
I think it's a huge challenge. It's going to be a very hard challenge to figure out how to maintain momentum on value-based payment and cost per target when there's so much growth going on. And at the same time, the pandemic has highlighted how important these things are. Providers who had moved away from fee-for-service and were getting capitated payments or population-based payments were able to weather the ups and downs of the pandemic much better. So it's this recognizing there's a burnout, and at the same time this is kind of a critical strategy for how you manage through a pandemic. And I think we're just kind of taking it month by month to see how do we not lose momentum, but also recognize there's a balance of everybody in the health system's exhausted right now.
Thank you so very much. Any other questions for Jeremy? Okay, we are on to Emery is going to be giving us a presentation on the utilization dashboard. Well, I need more coffee. And it's attachment 2 for any of you that are looking at your attachments.
Thank you, Kimberly. Good morning. Hi. It's great to be back and presenting from the board again. So I'm here to present the utilization report, and the agenda is seen here on page 2. We'll go through some of the data assumptions, take a look at some of the COVID-19 updates and impacts. And a lot of the impacts of COVID-19 and the way care is being accessed is actually going to kind of permeate throughout this entire report. And we'll go through some of those impacts. And then we'll also talk about aggregate costs, trend components, trends by place of service, and then some opportunities. And depending on time, we may be able to get to the appendix and maybe talk a little bit about the low value care. But feel free to let me know if you have any questions, and I'll try to address them as they arise. Thanks. Moving on to the next section. The data and assumptions, a little highlight on the data. So to keep in mind, the time periods we're taking a look at are essentially on a state fiscal year basis. So the current period, because we're looking at incurred claims, will be from July 2020 to June 2021. These claims obviously would be then essentially in the post Senate Bill 1067 or 200% of the Medicare world. It does incorporate some of the rules revisions, and that does impact some of the claims. And it's also post-COVID. So the impacts of COVID really started taking place in March of 2020 and lasted for a couple of months. A lot of return to care happening in this current time period. So some of the comparisons between the current period and the 1 year prior might be a little bit skewed as a result of delays in care. But as mentioned earlier, we can see a lot of ways that care is being accessed differently, and it's some of those impacts are longer lasting and maybe worth looking at to see if for future renewal questions or how addressing how people are now accessing care. The plans that we're showing here are self-insured. We do have MODA as self-insured. They became self-insured effective 1/1/19. The fully insured, we have Kaiser HMO, Kaiser deductible, and we do mention all care, although they're not included. The one other note down below, the Kaiser utilization reporting, there's some integrated care fees that we added in various categories. For some of the other categories, when we're talking about claims by types of service, those aren't included, but in total costs, we do include some of the 22 million for the current period, about almost 20 million for the 2 prior periods on the total cost sheets and some of the risk adjustment analyses. Any questions? No? Okay. Moving on to the COVID section. Thanks. So the latest updates in Oregon, this is just based on data for COVID cases through essentially Friday, I think, or Thursday, Friday of last week. So it's pretty recent. The COVID cases, you can see there was a big spike that happened in the second half of this year, peaking in September. It's moderated now, although it's almost at a flat level, I think, basically over the last week or two. The worry, obviously, with Omicron and how that's kind of taking over and impacting, we'll have to see how that is. But we were kind of moderating, and now I guess everyone's a little worried about cases coming back and exploding in a large way, as Omicron appears to be pretty contagious, especially so compared to maybe Delta in this case. The last on the right, there's kind of a heat map of Oregon and the cases. The biggest counties with the cases over the last 7 days in the dark red. So you have down in the southwest corner, Coos County, Tillamook in the northwest corner, and then Wheeler, which is actually pretty small, but it's actually much higher in terms of cases. We kind of capped it at 3. They're actually well above that per 1,000 over the last 7 weeks. Last week. But yeah, the cases in Wheeler are pretty high in this case. Everywhere else is kind of middle of the road, as you can see. But as Omicron, we'll have to see what happens as Omicron goes through Oregon. Any questions? Okay, moving on. A little bit of an update on the vaccinations. Some of this information actually is updated. We got late information that's updated as of middle of December. So for Providence, the vaccination rates are higher for choice by about 3 to 4%. So fully vaccinated is closer to 87% full, with a little bit less than 2% partial. Statewide, it's also higher. It's about 83% full and about 2% partial. MODA is still at that 79. Is at about the 79%. I think that was updated as of mid-December. Kaiser, we didn't unfortunately get updated vaccination information, but they have been higher, and potentially could have gotten a few more that are vaccinated. For comparison, across Oregon, about 71% of adults ages 18 to 64 were vaccinated. So for PEBB, vaccinations have been much higher than the statewide averages.
So Emery, Kaiser HMO and Kaiser deductible, they're both together in the Kaiser numbers?
Yes.
Okay, thanks.
Any other questions? Okay. Next slide, please. We're not presenting the RBC this month, but this kind of gives you an idea of the surplus for the self-funded plans as a result of, over the past, I guess, 10 months in this case for 21 in comparison for 2020. As you can see, the big dip in claims in the middle of the chart when COVID, the first pandemic, the first wave started back in March, April, May. The claims dropped, services stopped, and for 2020, there was about $109 million in surplus over the entire year. You can see claims started coming back and stayed relatively level through most of 2020. And then starting 21, January, some of it may be deductible impact there. But claims kind of stayed at about the same level as through mid 2020. The latest wave, if you remember, was in September, so like the last few months of 2021. We'll take a look and see if that really, how much of an impact it had on COVID. There were cases that kind of offset the deferred care, and then there's some return services that may have made the cost a little bit higher in 21, but you still had about $72 million in surplus so far year to date. So claims haven't quite bounced back to where they were pre-COVID, and we'll have to see what happens in 22. But there was still a surplus that was being built up during 21. Okay, next slide. One of the big questions about COVID is really what's happening with the delay in care, and as people don't go and have services, what's happening with the preventive care screenings. The two sections on the left are the preventive visits. So the dark blue, which is the second from the right, or number 3, are the most recent preventive screenings for year to date, so July through June of 21. And as you can see, they are up compared to 2020, and they're pretty close. They're still a couple points below where they were pre-COVID, but they're higher than where they were last year. For the screening rates, breast cancer is basically back to normal. Cervical cancer is a little bit below. Cholesterol is a little bit below. And colon cancer actually, I guess, is above our book of business and pretty close where it was pre-COVID. So there was a delay in services. I think if we take a look at it on a month-to-month basis, which was shown in prior reports, there was a big drop during that March through May of 20 time period. But services have pretty much come back, but maybe just a tick below where they were before. We tried taking, go ahead.
Yeah, I just had a quick question because are we reading it left to right? So, the dark blue is the 2018 to the light blue, which is now. Is that right? Am I reading it right? Or is it the opposite direction?
No, we are reading it left to right. So, okay. So for example, the employee preventive visits, the oldest time period is the one on the far left. So that would be 31% for claims through June of 2019. Mm-hmm. And then through June of 2020, after which, heavily impacted by the initial COVID wave, they dropped down in the green to about 26%. So you had a 5 basis point decrease. And then, so for June of 21, came back a little bit to 28%, which is a little bit below where it has been and compared to our book of business. So that, the number of services, the visits, I think that's something to look at, just trying to remind people the importance of doing the preventive screenings and getting your lab works done. It's not quite where it could be. It's not quite where our book of business is. So that's a area to for the plans to potentially focus on.
Yeah, and I guess just a comment, but it's just interesting to see that in some of the areas for preventative care, they've been much more successful getting people to get their care. For example, looks like the cholesterol screening rate has gone back up to 50% over the pre-COVID level of 45%, but other areas haven't returned to the same degree. And so just curious at some point to hear from the carriers, like what's working, why are some areas of preventative care, the carriers more successful getting people in versus others where it's been harder.
Yeah, definitely. And one other thing we tried taking a look at, and we weren't able to tease out data. I mean, one of the questions is, are these missed lower preventive visits, are there long-term impacts of it? We were trying to look at potential, disease stages based on various conditions, cancer, some of the others, and we're going to still try to look at it and try to get information. It's hard to look at it, but that's a question on their mind, and hopefully be able to get some information, whether it's yes or no. I mean, there may not be an impact really if services have kind of returned back and it's just a short-term blip. But we'll try to get that additional information in future utilization reporting. Next slide, please. So telehealth has obviously been a big increase. And for Kaiser on this first slide, it continues to, services continue to kind of be at pretty close to the same levels right at the beginning of the COVID pandemic, and keeping on that place. So for mental health and substance abuse, which are in the bottom sections of each chart, the blue, number of visits actually has been pretty consistent over the last year and a quarter. So people have used telehealth for mental health services and in Kaiser, and they've been keeping at those same levels. For non-mental health services, they're still pretty high, but they're kind of just dropping just a little bit in comparison. One thing to note in here is as these telehealth visits keep continuing, we'll see in some later data that in-person visits for Kaiser actually have dropped. So there's been kind of like a shift as people move from in-person to telehealth visits in the Kaiser system. The next slide has mode of province and statewide. The story here is a little bit different. Beginning of the pandemic in April and in May, the telehealth visits for non-mental health and substance abuse, as well as mental health, they were quite high. But for the non-mental health services, you can see the green portion of the bars are decreasing. So they've dropped 20% on average in 21 compared to where they were in 20 per month. So people in these plans are not utilizing not utilizing telehealth services quite as much as they had been. For mental health services, those still remain higher and are pretty consistent compared to the beginning of the pandemic. So a little bit different in utilization patterns between Kaiser and the self-insured plans. Okay. Next slide, please. Emergency room visits, another area where services dropped off quite considerably, especially during the COVID time period, and they've remained lower. So as you can see here, the number of visits, total visits have decreased 8% from the current period versus the prior. On a per member basis, that's actually 10%. I guess the good thing is the non-emergent conditions have dropped 22%, or dropped actually 23%, and the percentage of visits dropped from 22 down to 18% of non-emergent visits. So I guess people are using the emergency room less, and for lower acuity conditions, they've been avoiding emergency room. There's been an uptick in urgent care visits, so people may be shifting where they're using the services. They're no longer going to the emergency room for maybe headaches or urinary tract infections, or whatever the non-emergent conditions, and maybe going to an urgent care setting. So they're trying to avoid places where there might be COVID. And based on the decreases in utilization, there could be savings of $1 million or more if each of these, I guess, diverted visits for non-emergent ER visits was about $1,000. So the reduction in the non-emergent visits are potentially saving PEB additional dollars beyond just the lower emergency room visits. The next slide also has additional information about how COVID healthcare has changed. As you can see, emergency room visits is kind of the third section, but another area where there's been fewer services is inpatient admissions. For the most current time period, PEB is at about 42.1 per 1,000 members, and that's a drop of 10% from the prior time period. That's a pretty big drop, but it's actually something that's been seen in our book of business as well. A little bit more than the 4% drop in the book of business, but overall, fewer people are going to the hospital for inpatient admissions. Outpatient surgery, the most recent time period has increased. There's been a return of services for some preference-sensitive conditions like knees, hips, and others. So that's up 8% for PEB, but the most recent utilization of 174.9 is actually below where it was pre-COVID. So there's a pretty big drop last year due to impacting by COVID, but now there's some return services, but still below average. The next line is emergency room visits, where you can see is the drop, but some of those services may have shifted to the urgent care, which is up 42%. So people are changing to going to urgent care sections, to urgent care for a lot of their services compared to maybe emergency rooms. And then the telemedicine, you can see big increase, 149%. The other line, lab services below there, there's 10% increase, which a lot of that has to do with COVID. So there's a lot of COVID lab services that are happening. It's not necessarily, people are using more services there, but it's kind of the COVID lab services obviously increased, and it's a big impact on the costs there.
Emery, this is
Yes.
Kimberly. Do we know, have there been more urgent care? It seems like I see them more. Like, are they more readily available for folks so that they're not using the emergency room? Do we know, has there been an uptick in urgent care offices? Because I think they added like at least 2 to Woodburn. Salem has a lot. It's just kind of, I don't know if it's changed, I guess.
I believe, I'll have to check for sure, but I believe yes. I mean, it has been a place over the last few years where urgent care and walk-in clinics have increased, and there's been promotion of it. I think just urgent care, I know they've been promoting more. I mean, a lot of COVID services, testing, other things, getting your attention. So it could be a combination of that as well. But I believe, I'd have to check, but I believe yes, there have definitely been growth in the facilities, building the facilities, or changing of facilities to urgent care in this case.
I think they still may be owned by hospitals, but it seems like there's more available.
Yeah, that's definitely true. I think there's been, at least where I live, there's a few more urgent care facilities that are part of hospital systems here in Bend. Okay. Moving on. One area where we kind of wanted to look at, this is news, like long-term COVID impacts. So you may have heard of long haulers, or long-term COVID impacts, where members who've had COVID have new more chronic conditions post their infection. So according to CDC, some members who had COVID can experience new conditions a month or longer from the initial infection. The percentage of COVID positive members who have these conditions can range between 10 and 35%. I think as you go a little bit longer, the percentages go down. So 2 months, a month, 2 months after COVID, it drops down to maybe 10%. But there's definitely people who have additional conditions. According to some research, those additional symptoms are, difficulty breathing, shortness of breath, tiredness, fatigue, mood changes, and heart palpitations. So what we wanted to do was take a look at the PEB members who had COVID and to see how many of them had new additional conditions 2 months after their COVID positive test. So this may be undercounting people because we're relying on claims data to determine when they were COVID positive, and not everyone had claims that indicated when they were positive, but we wanted to see the impacts of long-term COVID on the PEB members. And so what we found in the table there to the right, that there were about 364 members, or 9% of those who were COVID positive, that had new diagnoses post their COVID test. The top two are fatigue and depression. So 3% in those of COVID positives each had fatigue or additional depression post-COVID. So, there are potentially longer-term impacts. I mean, it may not have been caused by COVID. It may be, causation, correlation, but there are members who are suffering a little bit more as a result or post their COVID positive test. They're more tired. They have additional depression. Mental health services have gone up quite a bit. Just trying to help them be more, potentially there could be things done to help them treat their issues, make them more productive at work, or make their lives a little bit better, because COVID has impacted them in a longer term stage here. And the table down below shows the impact on the cost. So those who had condition or more, their costs post-COVID were 22% higher than their costs pre-COVID. The additional conditions obviously has no additional cost, but there is additional costs associated with these members, and it's something to potentially monitor or help treat on a longer term basis here. Those who did not have the new diagnoses, their costs actually dropped a little bit. So they had COVID, got over it, they're basically okay. But those who have longer term COVID, they have additional conditions, additional costs, additional issues potentially in their life post their diagnosis. Any questions? Another thing we want to take a look at for COVID impacts, behavioral health. As people, the issue of behavioral health is people, are cooped up in their houses, have to deal with the issues of COVID long-term, other things, money. Anxiety has increased. Conditions of anxiety with members has increased 17% over the last 2 years. So that's a pretty big impact. Behavioral health utilization of claims has increased quite a bit, as we'll see a little bit later on. Depression diagnosis has increased 5%. PEB, compared to Mercer's book of business, that the percentage of members with anxieties and depression is considerably higher. So people are getting treated for more, but they're also being diagnosed for it more as well. So 60% higher for anxiety compared to our book of business, and depression's 89% higher in this case. What we wanted to do was to take a look at where the members are utilizing behavioral health, and potentially see as the first step whether there's a underdiagnosis or underusage across Oregon. And as the chart on the right can show, utilization, the darker areas are where utilization's happening compared to PEB average, and that's kind of metro area, Portland metro area, along the I-5 corridor and Deschutes County. And then the other outlying areas, you can see utilization's lower. The question, next steps is to determine whether it's access or maybe a stigma, whether having a behavioral health telehealth provider would be better. That might address the stigma if you don't actually have to physically go into an office and you'd be able to access it. But there's lower utilization in the more rural areas of Oregon, and finding ways to see to treat them might be next steps, at least for PEBB. Okay. If no more questions, we can move on to our next section. So aggregate costs. Taking a look at the aggregate costs for self-insured plans, the medical claims for the current, which are on the right-hand side, are about $569 million, which is about 0.5% increase from the year prior. For prescription drugs, the cost increase was 11.6%, and then increased to $112 million. So overall, combined, the total cost increased 2.2% to about $680 million. On a per employee per year basis, that was about a 1.4% increase, with the medical costs basically remaining flat or small drop of about 0.3%, but the prescription drug costs continued to increase. Those costs went up 10%, 10.6% on the per employee per year basis. The medical costs, some of it, there's a return of services, but lower reimbursement levels from this Senate Bill 167 or 200% Medicare help offset that. One other area with the revision to the rules, the newborn cost in the most recent time period post December 2020 actually decreased. I think that was an issue before, but the maternity costs kind of have moderated as a result of the revisions to the rules. For prescription drugs, specialty costs continue to be the biggest driver. For PBM, specialty drug costs keep increasing. The COVID vaccinations are also part of the prescription drug cost, and that's had about 1% increase on the prescription drug costs in there. On the next slide, for the fully insured plan, the costs did increase quite a bit, 8% in total, but that was actually mostly due to, actually almost all due to an increase in membership. So the membership, the employees enrolled in the Kaiser plans increased to about 10%, by 10%. And so on a per employee per year basis, the cost actually decreased. So the medical cost decreased on a per employee per year basis by 1.5%, and prescription drugs did decrease by almost 3%. So for Kaiser, a little bit better news than for the fully insured plans. There was a shift in prescription drugs. I think more for Kaiser went into mail order compared to in the facility, which is kind of to be expected. But that did have some savings as well for Kaiser. And on the next slide, in total, on a per employee per year basis, the cost increased by 0.7%. So it's well below the 3.4% mandate. Medical costs did drop overall, 0.6% decrease, but the prescription drug cost continued to increase 8.1%. And that is a little bit higher than where it was last year, but much of that's due to the vaccine coming in the current time period and inflating that cost. Moving on. Components of trend. So on a per member basis, the current year trend in the blue was a 1.3% increase, which is compared to the decrease during the prior year of 4.3. The 4.3 is due to COVID. You also had the Senate bill coming in, so that had a pretty big impact on the prior year. But the current year cost increases haven't been as, I guess, there hasn't been as big of an impact as there might have been with the rebound of services and post-Senate bill, 200% Medicare impact. The biggest component of the trend is utilization. As services come back, that's been driving the cost increase. Unit cost actually still is a decrease, 2.3%. So some of that's due to the newborn cost kind of moderating with the revision to the Senate bill rules and holdover of some of the decreases from the 200% Medicare. The member risk has increased a little bit compared to last year. Some of the last year's member risk may have been because they used fewer services and that had a resulting reduction in the risk score. But the risk is about 1% increase, which isn't, I think historically, PEBB sometimes goes 2 to 3% increase in risk per year. So 1% isn't as high as it could have been. And then the cost share leveraging does have an impact on costs, about 0.8%, pretty close to what happened during the prior year. The next slide has additional detail about trend components by service category. For the inpatient, the cost actually on a per member basis continues to be pretty low, minus 9%. As mentioned earlier, utilization is down, so fewer people are going and having services, fewer admits in that case. For the outpatient services, you can see there's still some savings from 200% Medicare for the unit cost, and a pretty big impact on the specialty drugs as well for some of the outpatient in this case. The physician utilization's coming back. 4.9% increase in utilization and the overall cost impact for physicians was 3.1%. And then prescription drugs, unfortunately, the unit cost continues to go up, and it's the biggest driver of prescription drug costs, about 9% in this case. And then all other, there on the right, the cost impact was 6.7%. Most of it's, well, all of it due to utilization. Telehealth actually, and some other lab services fall under utilization, so that's one of the drivers, additional COVID lab services. Okay. Page 23. This shows the trend components by service category. For choice, the largest components of change is still specialty drugs under prescription drugs, unfortunately. So that increased about $10 per member per month, or about 21% increase. Facility outpatient also increased quite a bit, but that's return to services, and then mental health services went up, and it's been a big cost driver. For statewide, the largest component change actually was a decrease in facility inpatient. So that resulted as fewer admits. It saved $10 per member. The facility outpatient specialty RX also saved some money as the 200% Medicare, but prescription drug specialty drugs cost continues to drive that cost. So for MODA, mental health is the biggest component of change, and prescription drugs, specialty drugs, continues to increase quite a bit. And then for Kaiser, deductible and HMO, they've actually had some pretty big decreases in the office visits, and that is really a shift in services to more of those are in-person visits, so the telehealth visits remain high, and so there's kind of a shift in how members are accessing. So some of the non-specialty outpatient other costs there, as mentioned for Kaiser HMO, that's telehealth, and that's kind of an offset to the non-specialty actual in-person office visits in this case. The MODA inpatient maternity costs mentioned before, we took a look at some of those. Those have moderated a bit with the rules changes. So hopefully that will be less of an impact going on in the future.
And Marie, I just had a question. You know, we have a large change in in a good direction for statewide around people getting their prescriptions and facility outpatient specialty drugs. I mean, that went down, right? And is that a result of us doing something very specific around that? Because I remember we had discussions as a board to change where people were getting their specialty drugs, whether they were getting them in outpatient facilities or in hospital settings. So anyway, I just wanted to know if you could speak to that, and it's fine if you don't have that at your fingertips. You can just get that answer later.
Yeah, no, actually, a lot of that is actually due to the 200% of Medicare cap. So we actually have a slide, I think a little bit later on, talking about a couple of specific drugs, but the reimbursement for specialty drugs and facilities that were capped dropped by like 30%, 20 to 30%. So the cost of the drug itself came down to the 200% Medicare level, and that had pretty big savings. So it's not actually utilization as much as it was just the unit cost of the drug. It's just, they were charging above the 200% of Medicare level, and now it's down at 200% Medicare, and that saved a lot of money on the specialty drugs.
Okay, great. That's really helpful. So as a result of the Senate bill then?
Yeah, it is a result of the Senate bill. I guess a little bit. I mean, one other thing that we looked at was a comparison of some of the drugs, the higher impact drugs, the more utilized drugs in the facility, to see on a per script if it's cheaper now in the facility than it was, would be in a different setting, like a professional service. It actually brought it down for a couple of the drugs we were looking at. It actually brought it down to the similar level between the outpatient and a professional setting. So, depending on the drugs, there might be some savings changing the setting, but it will have to be a little bit more surgical in terms of approaching that and just making sure that maybe the 200% Medicare is lower than what like other settings might be pricing it at, and just making sure that the value is still there in some of these programs.
Thank you. Appreciate that.
Okay. If there are no other questions, we can move on to the next slide. The risk scores by plan. So overall for PEBB, the risk did increase 1%. It varies quite a bit depending on the plans you look at. The most noticeable is really for Kaiser HMO. That dropped from 1.06 to 1. And, it's not necessarily that the members are getting healthier by 6%. It might have to do with non-claim services. So, I caution on this slide and on the next slide about that. There may be some services that aren't being captured in the risk score. And so it's artificially decreasing the Kaiser HMO costs in this case, or risk scores in this case. But for MODA, Providence, and statewide, you can see the risk scores are increasing a little bit. For MODA, it's about 2 points from 0.99 to 1.01, and then Providence is about 4%, and then statewide is another percent. But overall, risk scores are just a little bit higher than where they were before. And on the following slide, taking those risk scores and normalizing the cost of the plans. What we do here is we take a look at the overall costs of the plan on a per member basis, and then adjust for the risk of the member. So for a plan like statewide, where their risk is higher than the PEBB average, that brings down the cost of the plan, or the normalized cost of the plan, from $589 actual cost to about $546. And that $546 is a bit still, unfortunately, the highest cost. The more managed plans, Kaiser, MODA, and Providence, are below that. MODA is, based on this analysis, has the lowest normalized total cost. Providence choice is a little bit higher. And then Kaiser's at 540, but as mentioned earlier, the risk scores might be artificially depressed a little bit on that. So that may make their normalized cost appear higher than what it truly is. We'll monitor this as we move along. Okay. Following slide 25. Actually, 20. The next section. Now we can move. Sorry, let's moving on. Trends by place of service. I'll just quickly go through this as we talk through most of this. The biggest differences, all other, so lab services, telemedicine, that's causing a pretty big increase. Outpatient surgery, there's a return of services for in this case osteoarthritis, fractures, joint disorders, so knees, hips, preference sensitive services that dropped off due to the COVID time period. The one below that, the mental health, substance abuse, those claims continue to increase. It's up 10%. And then emergency room services are down. So mental health and substance abuse, those services continue to increase, just making sure people get the right, it's not a bad thing. It's just making sure, people get the services that they need, that anxiety's higher, depression's higher, and they're getting treated for that, which is good. Emergency room services are down. That's always good as well. And then COVID's just increasing lab services and additional costs there. Page 28. So, Siobhan, this is, I think, a little bit more, towards what was, what you were talking about in terms of the specialty drugs for outpatient facility. On the chart on the left, we have total drug costs, which changed about 3%, and that includes medical specialty drugs. So it's a little bit different from the other slides. The non-specialty drug costs, basically small increase in this case. Specialty drug in the pharmacy, those costs did increase by 13% and continue to increase. In the professional setting, the specialty drug cost per member was about smaller increase, 2.5%. But down below that last section, the specialty drug in the outpatient facility, that dropped 24%. And that is mostly due to the 200% of the Medicare, which just decreased the cost per drug. And a couple examples of that on the bottom far right-hand corner. So the specialty drug outpatient facility, Remicade, those costs dropped quite a bit. Fewer patients, but the cost per drug also dropped quite a bit. And then in TiVo, those costs dropped by a third. Some of it's a little bit fewer patients, but most of it's really because the reimbursement levels went down to the 200% of the Medicare level. And for both of those drugs, we did take a look, comparison on the cost per script between that and this in the professional setting, and they were basically in line with each other. So there's less of an incentive to steer people, but it's not to say that there aren't higher cost facilities, but those that have are capped by the 200% Medicare, those costs are kind of bringing them more in line with where we might see it in a different setting.
And Emery, looking between the specialty med outpatient facilities and the specialty med professional facilities, is it? Oh, I guess those are different drugs. Sorry, I didn't realize that because it looked like the numbers were increasing for the specialty med with those two examples. I guess I was just curious whether it's just that we have fewer people on Remicade and the other drug, or whether if utilization went down on those drugs along with the Medicare cap.
Yeah, for
or
Remicade,
if they just changed settings.
Yeah, for Remicade, I mean, I guess it could have changed settings as well. I mean, at least in the outpatient facility, it's a combination of both. It's just fewer people used it in the facility, and the cost went down in that case. But there could be I mean, Remicade has been around for a while, and so the setting may have changed as well. I'll have to.
Thanks for going through this.
Yeah, so I guess the other thing to note, the non-specialty PBM, there's the Jardiance that type 2 diabetes, that cost increased as there were more patients on that. And then the Pfizer COVID-19 vaccine, based on the data that we have, there's about $600,000 for vaccines. The Moderna vaccine was about mid $300,000. So, the vaccine cost impacts about $1 million, at least on the data we have through June of 2021 for PEBB, and additional cost increases as people got vaccinated throughout the year in this case. Okay. If we move on to the next section, some potential opportunities for improvement. Mental health. I think this has been of importance. I think it continues to be important as depression, anxiety conditions prevalence are high and continues to increase. Some of our recommendations: screenings, referrals for mental health and substance abuse disorders, evaluating and referring burnout with members, and potentially, longer-term people with COVID, just making sure that they're not feeling depressed, they aren't having fatigue, and then it's impacting them in other ways, additional conditions. Adequacy of access to providers, whether members can obtain timely services. I know this is something that we've been looking at, approaching that, making sure the networks are adequate, that that the providers, the provider directories indicate who's actually taking new patients. Nothing more annoying than finding someone who sounds good and then finding out that they aren't taking new patients. And then potentially investigating whether online behavioral health services can help supplement current networks if there are deficiencies, especially, and maybe addressing the stigma, not having to physically go to a place and just calling them on your phone might help increase utilization in some of the rural areas. One issue to just keep in mind there, access to good Wi-Fi, making sure that might be an issue in some locations. So just making sure that people do have access to Wi-Fi if they're, if you're going to be approaching an online behavioral health service, or even telemedicine in general in this case. Metabolic and cardiovascular conditions that we didn't show any real information on this in this presentation, but it's been discussed in prior presentations. It's a top condition, just clinical programs. Diabetes, I know that's something we've been looking at, and promoting condition-specific solutions for that. Low back disorders, musculoskeletal services are coming back, making sure the COEs, preventive screenings of, using lower impact services, preventing people from actually having surgeries, working on physical therapy and trying to redirect them to potentially lower cost interventions there. Specialty drugs. The facility costs have gone down as a result of 200% Medicare, and will hopefully stay relatively low, but those costs for PBM in the medical office setting, continuing to look at that and to monitor whether shifting of services and additional cost impacts, maybe use of specialty pharmacies to drive lower cost settings, or lower cost drugs, and move the settings there. And then the bottom one here, this is kind of a bigger topic, but the quality of care for members, trying to improve the care that the members receive and trying to steer them to high quality providers. We've talked about advocacy programs when we were in the IWG, when we were talking about the Lodestar doing our request for information on that. We were asking about, what programs are there using the data to segment and identify high quality providers, or potentially the low quality providers, and steering members to the higher quality, the higher more efficient providers. And there are programs out there, or there are third-party vendors who might be able to help segment providers and drive them to the higher quality, more efficient providers, and then using an advocacy program to steer those members to those high quality providers. That's another way to potentially save without and improve the care of the members that might be less onerous than some other methods, and like having to deal with the reimbursement levels. So that's a potential area where if PEB could look into for future. Any questions?
Emery, this is Ollie. I would just mention that we'll be hearing a little bit more about centers of excellence and number 3, musculoskeletal low back disorders, and some strategies that the Innovation Work Group have been working on, as well as the behavioral health work that they've been engaged in. And so more information to come on those two. Thanks.
Okay. Thanks, Ollie. The next section, I think we have some time for it, unless we want to take a break. Is what I guess we labeled appendix, but it does have some additional detail for the various categories. And so on this summary, for inpatient facility, as mentioned, utilization's lower. Kaiser deductible was an exception. They had a lot more maternity admits in this most recent time period. They are a smaller plan, so it had a bigger impact, but their costs went up a little bit. Outpatient office visits, when you include telemedicine, the overall utilization increased as return services and the usage of telemedicine improved there. Emergency room utilization and cost per visit decreased. Utilization due to COVID, and then some savings due to 200% of Medicare. Lab and radiology. Lab services increased quite a bit. Those were impacted by COVID-19. Radiology cost per service decreased a bit, but utilization did increase. And then prescription drug, the cost for specialty drugs, 71%. And then, as mentioned earlier, specialty drugs for PBM and in a medical setting in the office did increase quite a bit compared to, did increase, as opposed to facilities which had the decrease. And then moving on to the next slide. A little bit detail on the admits per thousand. So the decrease of 10%, as you can see across the board, MODA, Providence, statewide, and Kaiser HMO had drops, while Kaiser deductible had the increase due to the maternity. The allowed amount per admit increased 1.6%. MODA's cost did increase a bit, not as much I think as it has in the past, with the newborns and maternity costs not increasing as much as it had in the past. So overall, the allowed amount per admit was pretty moderate. The impact of 200% of Medicare may have not produced as big of a savings in this area as we had hoped, but definitely saw it in the facility, outpatient facility costs. Next slide. Office visits. Office visits per thousand did increase 5.7%, essentially all across the board. Some of the priors due to the COVID, and then shifting of services and additional use of telemed. Allowed per office visit dropped a little bit, especially so in the Kaiser HMO and the Kaiser deductible. The Kaiser HMO and Kaiser deductible, I think that had to do with some of the shifting of services to telemed, where the costs were a little bit lower. So it's a shifting of services in that case. And looked like there was a comment up above. Okay, I think that's okay. Slide 35. Emergency room, as mentioned earlier, visits went down, allowed amount went down thanks to the 200% Medicare. Level 5 emergency room visits did increase again. It's now 29% of total ER visits compared to 26.7% in prior. Some of it may have to do with some of the lower acuity visits maybe moving to urgent care. So it's not necessarily all coding of the, some of its lower intensity ER visits may have shifted to different services or like urgent care or telemedicine in this case. Lab services on the next page. The services did go up a bit, about 10%, mostly due to COVID. The allowed per service did not change too much, 2.6%, although the COVID test costs are a bit higher. So as you do more COVID tests, those costs will increase the allowed amount per service. And so that's something to keep in mind as we move on to we keep presenting these utilization reports. Radiology services are on the next page. The utilization is a little bit higher as some additional return to services. The allowed amount decreased thanks to the 200% Medicare. Some of those MRIs done in facilities and other services have a decrease in that case. And then prescription drugs. Allowed amounts increased despite the decrease in scripts as the unit cost increases. Kaiser HMO, there's a shift in utilization from retail to mail order, so it's slightly fewer drugs or scripts, but same number of days. Allowed specialty drugs in the PBM increased 16.4%, so that obviously is still a major driver of the cost. And then on to the next slide. Allowed per brand and allowed per generic. This allowed per brand script dropped quite a bit, 12%. That actually has a lot to do with the vaccine, which is, the only cost for the vaccine's administration, so it's about $40, $45 per script, and those are considered brand drugs. And so that's bringing down this allowed per brand increase quite a bit. And there's a lot of members who are getting those scripts, so it has a disproportionate impact on the allowed per brand. And then the allowed per generic cost, bit of an increase here, so about 10%, and that's across the board for all plans. The generic utilization actually dropped, but that's also impacted by the fact that members are going and getting the vaccine. So that number is probably going to remain a little bit depressed as a result of just a lot of people getting the vaccine and just having a lot of brand drugs in that case. The final section is the low value care. And actually, specialty drugs, sorry. So specialty drugs, at least on the medical and PBM, the cost, the number utilization is about 2.6%. Allowed cost is 1.8, but as shown earlier, the mix, the decrease due to the facility cost for specialty is offsetting the increases in the PBM and in the medical setting in the office visit. Specialty drugs is about 18.8% of total PEBB costs, up from 18.3. I think that's not as big of an increase as it has been, but specialty drugs are about getting close to 20% of the overall cost, which kind of shows you how big of a disproportionate impact it has on the PEB experience. And then down there, the final bullet, excluding specialty drugs, the allowed cost increase, which is currently 1.5%, would have been 0.8%. So specialty drugs still continues to drive the overall cost increase for PEB. Okay. Low value care. These first two we kind of show are based on usage of antibiotics for respiratory infections. It's definitely lower in 21. The COVID impacts on this. Respiratory infections, COVID, people aren't going to go into the office, and it's going to be fewer prescriptions as a result of that. But treatment for COVID and isn't going to necessarily have respiratory, and people are just using fewer drugs in this case. So while we are seeing a decrease, we're going to monitor this as we move on for 22 and beyond in this case. And then page 43. Arthroscopic surgery for knee osteoarthritis. For choice and statewide, the usage remains lower than where it was in 2020. So people aren't getting knee surgeries quite as often, which is a good thing. For MODA, numbers are a little bit lower, and you had a few more potentially return services in this case. And then Kaiser HMO had like a small increase here. Vitamin D screenings, those did increase just a little bit compared to others, but overall remains low. MODA continues to be the plan that has the most vitamin D screenings in comparison to some of the others. And that's actually the presentation. So are there any questions?
I feel like we need more sunshine in Oregon to get our vitamin D up, right?
Yeah.
I think all of us probably have a little bit of a deficiency in the vitamin D area. Thank you so much, Emery. Does anybody have any other questions for Emery? So we're a little ahead of schedule, which Emery, man, you get the Christmas present that keeps giving. So we're a little ahead. So let's go ahead and take a 10-minute break. And let's all, how about if I'm gracious? Let's start back here at 11:30, and we'll be ready for the consultant RFP update, if that works for everybody. We will start back here at 11:30. Thank you.
There's a lot.
Good morning. This is Ali Hassoun, PEBB and OEBB Director. Kimberly's having technical issues, so asked that we go ahead and continue. So I think, Brian, are you on? You want to give your consultant?
I am.
All right, go for it.
Welcome, members of the board. I'm Brian Olson. I am the OEBB and PEBB contracts team lead. I'm here today just to give a very brief consultant RFP update. As many of you know, we're in the middle of administering this RFP, so there's very little we can say publicly. That being said, we are continuing to wrap up evaluations this week into next. Most of the evaluators have completed their scoring or are just completing the scoring today. And so next staff will be doing all the tabulations and preparing sometime soon to make a finalist competitive range determination, which is an announcement on who we will interview as finalists. We expect to make this determination probably towards the end of this month. I mean, it's not ideal with the holiday seasons, but we are kind of limited on what time we have. And so those announcements will occur probably end of December or first thing in January. Hopefully, if you guys haven't yet received them, you will receive soon some calendar holds for the week that we plan to do finalist interviews, and that would be the week of January 10th. Since we're not going to make the finalist determination for a little bit longer, we're just going to have to keep some kind of generic holds on your calendars for another week, week and a half. Once we make the announcement, then we'll send out some more specific information and invites related to the finalist interviews. So with that said, Ali, those are the updates that we can share publicly at this time. If there are questions, I can answer what I can. I may have to take them offline, or it's possible there's some questions I just can't answer as we're administering the RFP. So I'll open it up for any questions. Okay, not hearing any. So thank you very much.
Thanks, Brian. Just checking to see if Kimberly, it looks like Kimberly just made it back on. Are you there, Kimberly?
Yes, I'm here. I'm sorry. Oh my goodness, that was nerve-wracking.
No worries. We're just got done with Brian's update, and looks like Margaret is up next with an IWG update.
Perfect. Thank you.
Mm-hmm.
Hi, good morning. So in terms of the innovation work group and their current status, the work group is meeting this afternoon. They have a couple of big topics on the agenda. The first off is they're going to be reviewing the final audit report from year one of the implementation of OEBB-PEBB's hospital payment cap. So that report has a couple of components to it that the work group will be looking at. Specifically, it looks at just compliance with the cap. Were claims administered by carriers in such a way that they did not exceed the upper payment limits established by the cap? And then secondly, consultants developing that report have included some other observations and things they've noticed in the data while auditing the claims for inpatient and outpatient hospital for both PEBB and OEBB. So that report is on the work group's agenda for this afternoon. Additionally, the work group is continuing its work on developing a Centers of Excellence program for musculoskeletal conditions, specifically for hip and knee replacements and spine surgeries. So at today's innovation work group meeting, we'll be hearing perspective from each of the carriers. Each of the carriers has 15 minutes on the agenda to share their perspective on development of the program, and including what they are working on in terms of some of the most important components of the program, as well as sort of a discussion of what some of the barriers or challenges to implementation thus far are. In addition to that conversation with the carriers, we'll also have some additional follow-up related to we'll have some additional consultant follow-up related to just next steps on the Centers of Excellence program. That program development is moving along within the carriers and the work group that is developing the program structure. There's some specific work still in process around the quality framework, as well as which quality being central to identifying the provider networks. And then also member decision support and identification of alternative treatment paths as well, so that we aren't developing a program that is centered on specifically only engaging with members at the point of surgery, but rather really engaging with them upstream. So that work is going to continue into 2022, as was mentioned earlier in the meeting. Value-based payment approaches and payment transformation in general, in line with the value-based payment compact, is also a subject that is high on the priority list for the work group moving into 22. So that will certainly be forthcoming on that work group's work plan, with more to be fleshed out in the coming months in terms of specific tasks and next steps on that. So are there any questions related to what the work group is up to? I certainly anticipate that as we get into early 2022, the innovation work group is going to have further updates and information to bring back to the board.
It doesn't look like it. So now I have no camera. So it's just, it really isn't Monday, it's Tuesday. So thank you so much, Margaret. And I will see you in just a little bit again with our next meeting for Innovation Work Group.
Yeah, wonderful.
We sure appreciate having you there for us. We really do.
Oh,
thank
absolutely.
You.
Yeah, thank you, Kimberly. Have a great, great rest of the day.
Thank you. So next up is public comment, and we do have an individual that would like to give public comment. And so, Mr. Perkins, are you with us? And I apologize that I have no camera.
I just saw Brian Perkins on the list, but now looks like, oh, there's Brian. Are you there?
Yes, I'm here. Sorry about that.
Oh, that's good.
There we go. Good afternoon. Or good morning, I guess.
Yes. Sorry. So my name is Ryan Perkins. I work for the state of Oregon. I'm a PEBB member on Providence statewide. And I'd like to speak about how Providence and Kaiser are treating healthcare claims related to this preventive therapeutic medication regime called PrEP, and specifically some concerns that I have about the drug being treated as preventative. So PrEP is short for pre-exposure prophylaxis. It's a preventive treatment that allows people who otherwise have a high risk of acquiring HIV to not have to worry about that with a single daily pill. It's really effective. It's also extremely expensive here. I pay about $2,000. Well, the list price is $2,000 a month. I have not had a copay assessed, I think, since March of 2020. But it's very expensive, but it's also extremely worthwhile because by having people take PrEP, take this preventive treatment, we can very effectively prevent the transmission of HIV. And obviously, that's extremely desirable. So in July 2021, the Centers for Medicare and Medicaid Services announced guidance that clarifying that PrEP treatment, including the prescription, the lab and clinic visits associated with maintaining that prescription, have to be covered by insurers without any cost sharing whatsoever. I remember seeing a news story about this guidance, and I called Providence after I looked over it, attempted to dispute some charges that I'd been assessed for treatment related to my PrEP prescription. And I explained that this guidance had come out. Providence told me that the claims were billed incorrectly, and that I should contact my doctor's office about the billing code and ask them to resubmit the claim. Under a preventive code, that didn't work after many back and forth calls with Providence and my providers. So after about 3 months of these calls, I got in touch with the Division of Insurance Regulation at the Oregon Department of Consumer and Business Services and the Center for Consumer Information and Insurance Oversight at the Center for Medicare and Medicaid Services, and submitted complaints to both of those agencies. So Providence has since agreed to cover costs of my PEBB-related claims back to June 2020. And I'm glad that they're doing that. They also told me they're reviewing about 10,000 lines of claims to reflect that change in practice. I'm concerned, though, that there's still inequitable treatment of public sector workers covered under PEBB, specifically what was going on before June 2020, and whether they were whether these claims came from a specialist's office or a primary care office. PrEP has always been a preventive care service. It should have always been covered without cost sharing. Providence shouldn't have needed federal guidance to identify it as a preventive care service. And I think that at least some of these claims, when they came from a primary care office, were covered in full for at least some people. I'd like to ask the PEBB board to investigate Providence's practices around PrEP-related claims before June 2020, how Providence is identifying these claims that are now subject to reviews for refunds, and how and that process of assessing refunds generally, and then the past and current practices of other PEBB insurers around PrEP-related claims. And then I'd also ask the PEBB board to investigate whether the insurers it contracts with have a robust and speedy process to conform with updated guidance from the Centers for Medicare and Medicaid Services about what needs to be covered without cost sharing. I don't think Providence has such a process. And then finally, I'd ask you to investigate billing practices regarding preventive care services provided at specialist clinics, and to ensure that these are being provided equitably compared to preventive care services in primary care settings. And there's more on that in my written testimony. Thank you.
Thank you so very much. We appreciate you coming before the board. What I would ask is maybe I could, if staff could put together some information related to coverage and equity of PrEP therapy, and then possibly bring the carriers in to discuss this. If maybe staff could help me with that, I'd greatly appreciate that.
Yeah, we can definitely have Mercer do an investigation and bring back information from all carriers to the board. And I really appreciate Mr. Perkins calling this out, especially from an equity standpoint, and which we would also perform an equity analysis as well. And one thing I would propose to the board is performing a broader analysis, even on centering equity in our preventative benefits. We saw the data earlier, and we really have a big hole to dig out of due to care avoidance over the past couple of years and during the pandemic. And in briefly discussing this with Mercer, what we thought we could do is put together a roadmap of activities related to the coverage or coverage policies around preventative services from all carriers, and develop strategies in the short and long term, and not just related to PrEP. That's obviously a focus of today, but preventative services and benefits in general. So again, appreciate Mr. Perkins' comments and coming before the board.
I just want to say too, I appreciate, Ryan, you speaking to us today and making a broader ask beyond just Providence. It sounds like you got your individual concerns answered around getting your care changed to preventative care, but that was a long process and it was hard, and lifting that up for everybody else, as well as looking into MODA and Kaiser too, is important. And I appreciate, Kimberly, your recommendation that we follow up on that as a board. And I do support, Ollie, your recommendation. As we see with a lot of preventative care services, we need to make sure people are getting the care that they need. So just want to say overall support the direction we're going with that.
Thank you. Rose, did we have any other public comment that might have come in today that we didn't know about?
Sorry, no. I was having technical difficulties too.
It's the mute button, right? We want to keep it on as much as possible so we don't get in trouble with the microphone. Thank you, Rose. And so that is the end of our agenda for December 21st of 2021. Kind of a nice little number there we've got going on today. I want to personally, on behalf of the board, thank all of our carriers and all of our consultants and all of the individuals that make us look good or make this job a little easier for us on the board. And thank you for always smiling when we ask those questions that you're just like, you just got to dig up more data for us. And we just keep asking and asking and asking. And we appreciate that you honor us and you continue to give us the information we need. I want to wish you all a very safe holiday season, no matter what you believe. I just wish you all the best in health and maybe a little good cheer and some family time and maybe just a moment in time that it's not about COVID, right? So best wishes and happy, whatever that looks like in your life. And thank you all so much. And it is absolutely my pleasure to be your chair. Thank you.
Thank you, Kimberly. Thank you, Mark.
Yes, Mark.